So the most pathological finding was the 40 to 60 RBCs per high power field. Number 2, granular casts are casts that cells have been broken down. Extreme stasis, you see broad cast, that could have been waxy cast. So you can write, I mean, you at least have this part of the test, since I remembered to do the short answer separate. Transitional epithelial cells can be not only central nucleus, so it might help you to write central nucleus too, or caudate. Because that way when you go back to study, you got extra stuff there. Crystals associated with liver disease, leucine and tyrosine, so it's A and C. Common stain used is the Sternheimer-Malbin. So it doesn't hurt you to write little extra stuff for studying in the future. Cholesterol pathological, cysteine, C pathological, calcium carbonate, normal alkaline, B. Leucine, C pathological, tyrosine, C pathological, calcium oxalate, A, normal acid, triple phosphate, B, normal alkaline, uric acid, normal acid, and ammonium biurate, normal alkaline. Cysteine goes with, envelope shape goes with E, triple phosphate. Thorny apple goes with D, ammonium biurate. The slice through tree trunk, or you could put there snail, cinnamon roll, would go with leucine, C. Hexagon shape goes with cysteine. The stack of needles goes with tyrosine. The 2 types of microscopes, phase contrast bright field. Hallmark findings in nephrotic syndrome are oval fat bodies and fatty cast. A key reason for cast formation is, of the 4, marked decrease in urine flow. You could write next to that stasis, so you know that if you see that term, it means the same thing. The stain used to identify fecal fat is the oil red. Remember I said they have to, if you think you have a oval fat body, you got to ask pathology if they could stain it with oil red, because then it takes up the red stain. Following sediment under high power with a clean catch that was most significant was the many bacteria. It's a clean catch. You shouldn't have anything there if you're normal. And even if you didn't do a clean catch, you should only have like few occasional bacteria. Oval fat bodies are renal epithelial cells that absorb fat. The cast commonly seen with pyelonephritis is the white cell cast. Common parasite from the female's vaginal area, Trichomonas. Yeast can be seen budding or in hyphae. True, we saw both yesterday. Hallmark for tubular necrosis was renal epithelial cast. The most abnormal was the 10 to 20 white cells per high power field. There was pink sediment at the bottom of the tube. It was collected at 7, performed at 3. That was amorphous sediment. That pink sediment reflects. Many epithelial seen under low power with eccentric nuclei. It should be the renal type. The type with severely decreased or absent tubular flow, waxy, or you could put broad. Hallmark findings of acute glomerulonephritis are red blood cell cast. So those questions should have helped you on the case studies, okay? And that little handout I gave you with the hallmark findings. Common drug-associated crista is the sulfa. The most valuable aid for initial identification of crystals is the pH. Whenever I give you another slide test with all the crystals, you're going to get pH as a clue. Okay? Because that is the key pH you look at, especially on all your normal ones. And the pathological ones are acidic. The typical order of degradation, when it's degrading, the best one was cells degrade into granules, and then they become waxy. And the clue was when you have extreme stasis, this is how it's going to get to the waxy. Nephrotic syndrome goes with oval fat bodies, fatty cast, acute glomerulonephritis, increased red cell cast, bladder infection, whites and bacteria, no cast, and if you want to put next to this, cystitis. Renal failure would have the anuria, waxy cast. When you're going into renal failure, you're going to hardly have any output. And what's the other clue? What would the GFR be if it's renal failure versus chronic glomerulonephritis? Who's going to have the worst one? Renal failure, less than 25 GFR is what they flag in the book. So chronic glomerulonephritis is bad too, but it's not going to have complete anuria and not going to have the creatinine clearance or the GFR as low. Pyelonephritis, the key thing was bacteria and white cell cast. Creatinine clearance was the glomerular test. Osmolarity, Fishberg, and Mosenthal were the concentration test, and we had that all on the board yesterday. PAH was the renal blood supply. That's what we took the time to write on the board when we were done. Normal urine, and I didn't say anything about water deprivation, is 3-to-1. When there's a problem when you deprive the water and it still is 1-to-1, okay? An exogenous substance for glomerular filtration is inulin. That's endogenous. Protein would be endogenous. Urea would be endogenous. Problems occurring with the kidney concentration is expected if it stays at 10. Hey, you know what? This isn't correct.
I'll say that isn't.
No, it isn't correct. Since I didn't, I'll just make sure everybody we'll make that a bonus one. Let's write though what is correct about it. Normal urine to serum ratio without water deprivation is 1-to-1. Okay? With water deprivation is what?
3-to-1.
Yeah. So I'll make this a bonus. Everybody will just get a bonus point added. Is 3-to-1. So write this, okay? So write it so that way you know it the way it should be. Okay? So I wrote it incorrectly. For 3-to-1, I should have put water deprivation. So keep it that it's 1-to-1 without water when you're fluid restriction, and 3-to-1 if you normally, for normal. Okay, that way you have it correct. Osmolarity can be vapor pressure or freezing point. Nephrogenic, the defect is in the tubules. It can't respond to ADH. And neurogenic, it's the inability of the kidney to produce ADH. So, yes.
I thought nephrogenic, the kidney was fine.
Anybody have the chart handy? It's in the book, because the chart says it.
It's neurogenic, the kidney's because the way I remember is neuro has to do with the hypothalamus.
And I had it right the first time on my key.
No, you have it right. You have it right.
DNA.
It's right now. Yeah, you had it wrong the first time, you got it right this time.
Yes. Okay, and it says on that chart, when you do the ADH challenge and you inject it on the neurogenic, your osmolality is going to be greater than 800 because they can't produce ADH, but when you're injecting it, you're providing it for them. And then nephrogenic can't respond when they inject ADH because their kidneys are the problem. They produce ADH, but the kidneys can't respond to it. So nephrogenic is the problem with the kidney. Neurogenic, they don't produce ADH. Okay, and the GFR, and I'll look at everybody's nomogram. I'm going to give you some leeway here because I know the lines are so little. So you just have to say normal or abnormal. So this one, did everybody get that it was 1 mil per minute? And then you set it up with urine, times, and this is mils per minute. These two, the units cancel out, and then you divide it, the surface area by the patient surface area, and it's abnormal. And then 3 mils per minute. Did everybody get that? Do you remember? And then it's a smaller person because it's going to be a lower specific gravity, and it's still abnormal. It's higher than abnormal, but what you worry about is when it's low. Okay, I should have thought about my numbers better. 1500 RPM, 5 minutes. For interstitial nephritis, urine for eosinophils with the Hansel stain is what I was looking for. If, and I corrected on yours, but when it was less than 400 still, it was nephrogenic because the kidney couldn't respond to the ADH. In the neurogenic, the ADH you supplied what they couldn't produce, so it did respond, and that one was the neurogenic. Yes.
What if you didn't put the, with Hansen status, you just put urine for eosinophils?
I'll see what everybody does. It might be a bonus point for someone who did the Hansel stain, or it may be, I'm gonna see. Because sometimes it acts like, oh, everybody didn't do it, but then when everybody does it, then that's what it should be. So I'll look at what everybody puts, and then I'll decide. You at least had to say urine for eosinophils. Hansel stain will either be part of the grade, or it'll be a bonus point for the person who put it. And this would be a liver cancer. So if you want to, when you get your thing, urobilinogen was positive. The cast, you should have put leucine. I didn't even read my test right when I did the key. And they're both elevated when it's something to do with the liver. And you know if you have leucine and tyrosine, it's something to do with the liver. So those would have been the two key abnormal things that went with anything to do with the liver and the crystals. So did you guys circle those?
One of them.
I circled protein, yeah, anything
And
I'm
did
not.
everybody get cystitis?
Mm-hmm.
Bacteria and white cell clumps, and it said there were white cell clumps? Did everybody get diabetes mellitus and diabetes insipidus? This one we don't know if it's nephrogenic or neurogenic. We'd have to do that ADH challenge test. But this at least you should be able to say, and the polyuria was the big thing. And did everybody get pyelonephritis with the white cell cast? And then this one would have been okay to look on the screen too, because then you'd see the reddish brown, but that was the red cell cast or the hemoglobin cast, and that should have been the key thing you flagged, acute glomerulonephritis. And this one, there were waxy cast, and the GFR was 50. So it should have been chronic glomerulonephritis, and they still had oliguria, 200 to 400. And then this one should have been nephrotic syndromes, the Maltese crosses, the fatty cast oval fat body, and those are the key things with, and polarized light. That's the only condition we've talked about using polarized light. And then renal failure, you see the BUN and creatinine were on both of them, but then the GFR is less than 25, and it's going into anuria. And then the artifacts, all you had to say for the two things at the bottom. So did you guys do okay? Because that is the key. Do the hallmark findings. Those ones, that little handout I gave you was from the CAP book. So they're gonna have to give you the key findings on your registry. So sometimes you'll get all these results. You just gotta find what is the hallmark finding that goes with it. Okay. Tell me, let's review before we do the body fluid PowerPoint, and then we'll take, that one's not too long, and you should be good at it.
I missed 9 because I got the
Since you
bonus
guys
for this
just
one.
finished
I
hematology,
missed 12. I got the
I'm
bonus.
expecting you to be good at it.
I mixed up the pyro and the...
So, tell me what amino acid pathway goes with Hartnupp's disease, and tell me the key finding. Which pathway, which amino acid pathway? Tryptophan is the pathway.
And the urine started to turn blue.
So it's called the blue baby diaper syndrome, and it's the tryptophan pathway. Which one tests positive with the Guthrie test from a heel stick within 5 days? And it's one of the most common amino acidureas. PKU, phenylketonuria. And what is the bacteria used in the Guthrie test, and what happens if there's excess phenylpyruvic in your urine? Bacillus subtilis, so that's not like anthracis or something like that, it's subtilis, the normal floral one. And does the bacteria grow or not grow in the presence when there's hives? It will grow. And it's the, what pathway is it? Phenylalanine, tyrosine, those are the two pathways. So what amino acid problem is the only one involving a kidney defect? Cystinuria, and what is one of the things that happens to them in their urine commonly?
Do you see the cystine crystals?
And then they accumulate and become what? A kidney stone. That's common, and that's the only one we talked about was the renal defect. Which one is, what are the 3 branch-chained amino acids, and what is the name of the disease, and what is a key finding about that disease? You may remember? What's the smell? Gives you a clue of the name, maple syrup, and it's valine, leucine, and isoleucine are the 3 branch-chain amino acids. Which 2 are involved with cancers of why you get the disease? Melaninuria or melanuria, 5-HIAA. So we know in what pathway is melanuria involved in? Phenylalanine, tyrosine, and what pathway is the 5-HIAA involved in? Tryptophan. What is the cancer in 5-HIAA? The argentaphin cells in the intestines. Okay? Then tell me, if I have a porphyria, what is the most common one? What is missing? And what is the key finding? Lead poisoning. It's missing the enzyme for the delta-aminolevulinic acid. And what is the key finding that'll give you the clue on the urine? Port wine red color. Tell me how you would determine a carbohydrate disorder that you already know and have done. Okay, the glucose is negative. Positive because it's the reducing sugar like galactose, lactose. Tell me, what is the disorder when uric acid builds up? It's called a name. It's 2, doubts the disease it'll go with, and there's 2 words to the name. That's what you gotta know. Increased uric acid, and it's the Lesch-Nyhan. Okay? Then there were those mucopolysaccharide disorders that affect your connective tissue, your skeletal structure, and there were 2 H's and an S. Hunters, hurlers. And there's a restaurant downtown St. Louis. Well, it's called San Filippo's, and it's right downtown by the Rams, because I've been there before for a game. Tell me the 2 urines that darken upon standing as the clue. And what pathway? Alkaptonuria, melanura. And so they're all in what pathway? Alanine tyrosine. Okay, so that was review from yesterday, and that'll be on next week's test. So tell me what you remember about the formula for doing a body fluid. We're going to start them fresh. What we're going to do on next week's lab is we're going to do the body fluid first, red and white. Then we're going to do the 4 urines. So we're going to reverse order. And so next week, both labs, you'll do the body fluid first, and then you'll do the 4 urines, and then we'll start adding a diff, and we'll do a diff together just to introduce you to lining cells and macrophages. Those are really the new ones. We at St. Elizabeth's couldn't even identify mesos versus macros, but I make you identify them for us because I don't know what they'll have you do at each clinical site. And then we would put review by pathologist. So we would say if we had 50 neutrophils, 20 lymphs, and 30, we'd say unidentified large mononuclear cells, see pathology report. And then our slides would have to go down to the pathologist. That way, anything that was weird that wasn't a normal white cell. And normally the white cells are gonna be lymphs and neutrophils first, some monos. So it's not like you're gonna break any neutrophil down into a meta or a band or a myelocyte or anything like that. So you should be pretty good on your normal cells. It's just we gotta add the mesothelios and the macrophages and and not all of them are called mesothelios if they're a lining cell. So it should be at least the blood cell part. We used to try to do urinalysis in the spring before heme, and that was disaster. I was having to do a rush course through the normal cells, then do body fluid cells, and they hadn't even had hematology. It goes so much better if it's after hematology. So this one you should be pretty comfortable with. Because of hematology on doing the counts. The hardest thing for students to do is to adjust the area they count. And more mistakes. A lot of people, even at the labs, have a built-in, when you put it in the computer, it'll calculate it for you because they make you put in fields because they're getting so many errors of people not calculating correct on their own that a lot of labs have built in. So anybody remember the formula?
It's the average times the dilution divided by the area times the depth.
Oops.
Oh no, did I have it backwards?
And what area were you used to doing for hematology when you're doing a blood count? What was your, well, let's review this. What was your area, what was your dilution on a red count?
200,
And then what was your dilution on a white count?
100,
And then what was your area you counted on a red count? 0.2.
1.
You're counting
Yeah.
5/25ths of the center square, that's only 0.2. That's 1/5 equals 0.2. And then what's the area you counted on blood whites? 4. Now you got it. This is what's gonna vary and this is what's gonna vary. So our dilution, we call it straight plated. If we did something undiluted, and spinal fluids almost all the time come clear colorless. So they're gonna be undiluted. So if if it doesn't look like there's anything in it, you gotta count more area. So when we do lab next week, I will actually give you a rule sheet of when you count the whole grid. So remember, a lot of people have struggled with the grid. Does anybody know what each of the 9 squares is?
16 or 9?
1 millimeter squared. So there's 9 millimeters squared. So if I count just the 5 center one, that's 0.2. If I count the whole grid, that's 9. What is the depth always?
0.1.
So if I count the whole grid, I'm going to divide by 0.9 because 9 times 0.1 is 0.9. If I count the 5 center squares, 0.2 times 0.1, it's going to be 0.02 you divide 4. So where people make the mistakes, they don't calculate the area times the depth correctly. If I'm doing something undiluted, all I'm gonna do is take the average. So on a clear colorless spinal fluid, you're gonna take the average number of cells you counted on the whole grid, divided by 0.9. Because 9 is the area you counted, but you have to multiply that by 0.1. If you understand your formula, you're gonna be ahead of the game and not make mistakes in your calculations. So your first test next week is gonna be calculations, before we've ever even counted one. Because I gotta get you to understand so you don't make the errors on your calculations. So, does everybody have a sheet of paper on their own, or you need a sheet? I'm gonna give you some to practice for Monday. So, just, if you got a sheet with lines, take it. If not, if someone wants a copy of this, I don't care. But we're gonna, when we keep this paper and when we're done with the PowerPoint, it's not very long, we're going to give you 5 problems so that you will practice them, and then we'll go over them, and then I'm gonna let you write 2, so you can write 1 for one. Okay, so let's go through the PowerPoint, and then I'm gonna give you problems, because that's what's gonna be on your test. So I'll give you practice ones for homework, because I think if you understand your calculations, you're gonna be ahead of the game. Because you've already done manual reds and whites on blood, so that shouldn't really be that tough. You've already seen ghost-like red cells created, and the white cells, you've already done manual whites. When I get to I usually start with just doctoring up saline with the buffy coat of a purple top. That works really well for getting whites and getting some reds. Then when I get real fluids from St. Elizabeth's, I end up usually having to doctor them up a little bit because everything deteriorates. Just like urine, the cells aren't going to be around long. But when you get to a mesothelial cell or a macrophage, you're going to see they're much, much bigger. Your largest white cell is your monocyte. They're much bigger than that. So when you're counting your manual count, if you see cells that look way bigger than a white cell, you still count it in the white cell count. We're going to go do it how St. Elizabeth's did it. We counted our lining cells and macrophages as part of our 100-cell diff. Some places are not. They're going to count only your blood cells, normal blood cells is your 100. Then they're going to just report how many extra cells they saw were mesos and macros. Ours is going to be part of our 100-cell diff, so we're going to count them in our white count. They'll be accounted for in there, okay? It's funny, I probably, if I had one department, hematology was always my favorite. So it was DJ and I on the weekends, and we had micro because micro was elsewhere. So we'd get a spinal fluid, and you had to have it done in an hour. And you had all the setup for micro, the red count, white count, the diff, and we had a bacterial antigen panel that we had to do. And we always got to the point, I'd say, hey, I'll do all this hemocytometer and the diff because I love that. And we had to do so much here with the students. We were great at the hemocytometer. And he'd say, okay, I'll get going and set up the micro and the gram stain, because you have to be very careful on it. And this is a big reason we do spinal fluids for bacterial and viral meningitis. You're going to do, that'll be our first lecture after this one next week, is spinal fluid. You're going to do a gram stain. We had to filter our crystal violet because we couldn't take a chance of any crystal violet sediment we call gram-positive cocci, and they're going to think they have bacterial meningitis and treat them. So they were very stat and very critical that you called it accurately, because bacterial can kill you quickly if it's misdiagnosed. So that's going to be our first fluid we do, followed by the serous fluids. The most fluid I ever did in my whole career was probably pleural fluids. So serous fluids are fluids that go around the different tissues in your abdomen. So you have pericardial, fluid around your heart. Pleural is the same. You'll hear the fluids called thoracentesis. It's around your lungs. And then you have peritoneal is around your abdomen. And in here, I'm going to teach you how do you distinguish if it's a fluid that is called an exudate and it's caused by an infection or a malignancy. And then I'm going to teach you if it's a transudate. I'm going to teach you how to identify if it's caused by something like congestive heart failure, where it's a systemic problem, why these fluids are building up. Then we're going to talk about synovial fluids. Those were my ones I disliked the most. They get real stringy, and from in your joints, like your knee, elbow, shoulders, you have hyaluronic acid or hyaluronate, and it's what keeps them cushioned. Well, that is tough to work with on a fluid because it's very stringy. You can't hardly get the liquid to do like a total count on a knee or some joint that they're worried about. There's 5 groups we'll worry about in synovial. So at the lab, we kept this stuff called hyaluronidase, ASE with an enzyme, and it would clear up the viscosity. And we kept it in the refrigerator. So if we got a synovial fluid that was stringy, you at least had some way to counteract that real viscous stringiness, which is good for your joints, but it's not good for doing testing. And then the seminal fluid, Barb was saying there were some good videos on the motility, viability and motility. I bring in the controls from work. They let me dilute it with their semen diluting fluid, and then we'll do the low and high counts. And they're easy. You count the same area of a red cell, the 5 R's I call them, and they're easy to identify. The sperm, there's no problem, and you just make sure they're intact. Has to be a full sperm with the head and the tail. And then amniotic fluid, we don't do any testing in here, but I'll teach you how they determine if the baby's lungs are mature. We do a thing called an LS ratio or a PG. They can measure the baby's creatinine to see if the baby's lungs are mature. And they have these bodies now they can detect on certain analyzers called lamellar bodies that can let them know if the baby's lungs are mature. And there's alpha-fetoprotein. I don't know if you already talked about that with Barb. That goes with spina bifida. And HDN, you'll hear a lot about that with blood bank. Hemolytic disease of the newborn, if bilirubin is elevated, they can tell if there's problems like that with the baby as well. So these are the remaining fluids. So you figure we have basically, the only other thing that I'll talk about is a small PowerPoint on fecal analysis. So this is all we have left, basically, is 1 PowerPoint per fluid, and there's one with fecal that we'll do an occult blood, and we'll do a pregnancy test. I think we're going to do those next week. They're very quick, and we'll do, so that would be good to.
You don't have to doctor anything.
No, that would be good. The longer you're pregnant, though, the less. Anybody know what the pregnancy hormone? Human chorionic gonadotropin, and it decreases the longer you're pregnant. So I think I told you I brought in one of a girl who was pregnant, Laura Dalton, 8 months, and I brought her afternoon one because I just got it in the afternoon, got it, and it was negative. The morning, I'm sure it would have still been negative, but it deteriorates the further along. So I love doing serous fluids, especially the thoracentesis. A lot of times they're like a pale yellow. So what you're going to do, every body fluid, you're going to put color and clarity, just like we've been doing. And then you're going to do, the only one we do volume for is synovial. So you'd measure it in a graduated cylinder and put on the report. You're going to do a manual red and white, and then you're going to do a differential. So there's always those pieces. On your practical, I think I had them do a spinal fluid, a pleural fluid, and 4 urines. So you have a practical that'll have 2 fluids with the diffs, and I set the diffs up at 2 stations. So there'll be a diff associated with one fluid, a diff associated with another, and then you'll have to sit at your desk doing your manual red and white. So all of that should at least be familiar techniques, that it should be just adding what's different in a body fluid. But at work, especially on a clear colorless spinal fluid, you have to count the whole grid, and there's not gonna be a lot, so we would keep 2 counters. So we'd go along, and when I'm counting the whole grid, I start at the top left and I go all the way across to the top right, then drop down where I know I haven't counted and go all the way across. I don't go box to box to box. I just start at the top and work my way down. And sometimes students struggle with that, but you gotta know your grid. And I'll give you another grid next week when we start, and the counting rules. I think that's the biggest thing that students struggle with, is counting the whole grid and keeping track of where they're at. You're gonna see a lot, you know how urines you should do within an hour. I think you're gonna see not all fluids are handled properly. Spinal fluids are stat. They're gonna be handled right away. Usually the doctor takes 4, you love it if they get 4 tubes, but they'll at least do 3. And then when we get into that lecture, you're gonna have to tell me what department gets, they're clear tubes and they'll label 1, 2, 3, and you gotta let me know what department 1 goes to, 2 goes to, and 3. And there are reasons why they're delivered in a set way. We were always thrilled if they had enough of the puncture to get a 4th tube, because then you had extra testing you could use from it. But they'll refrigerate if they don't have time, or if you're getting it sent from a lab that doesn't do the body fluids to your main lab, then the main thing, they have to be refrigerated. But they're best if you do them right away. You know, I was always someone who always did my stuff right away. I didn't go batching anything. I think especially anything to do with cells, we've seen how fast blood cells go away. Just me getting them in the morning, we've only seen the white cells stay around. The red cells are almost all gone. The hemocytometer, so remember, you're gonna read, if I'm doing a clear colorless fluid, you're gonna go all the way on side 1. Then when you're done there, you're just gonna scoot aside and do side 2. So you always have to count both sides, take your average, and you still gotta match within 10%. So if you got 400, you gotta match within 40 on your next slide. So every time you do, and what we do, we kind of, since I'd have to doctor these up, what we do is we'll do different fluids on each side, then we swap them, and then we'll put the values of everybody, will write down what they get, and put them on a sheet. And that usually works really well to see if we're getting consistent counts. And then the main thing is just, this is critical. You gotta know your formula, and you gotta know how to not use a dilution and not use a different area to count. Some books will show you that they keep the depth up here, and they'll get it out of the bottom and they'll times it by 10. Since it's 0.1, if you bring it to the top, it's times 10. I keep everything in the formula how it should be. So you just got to remember to take, this is what people do on the test too, is not take it times the depth, and they'll divide it by 9 or divide it by 4 or divide it by the 0.2 when they forgot to multiply that by the 0.1. So probably calculating errors are your biggest errors with doing body fluids, even out in the real lab. There's a neat thing you're all going to get exposed to. I try to get what are called cytospin differential slides. You guys, you know, when you're going to have to do a lot of diffs when you go to your clinical, that they make you make the slides. You know, I always put the drop, how I would do mine, I put the drop, I draw up my slide, and then I take off. And I always usually did it down on the, you're going to have people that teach you to do one slide sideways, go to the blood, and pull out. I don't care, whatever technique works for you. A lot of times the students say, oh, they showed me this way and I really got good and I'm really fast at it. Well, you don't do that for body fluids. You don't have enough cells. You'd be there all day looking for your 100 cells. They have this wonderful centrifuge process called a cytospin, and it has a little funnel with a little hole in filter paper. So when it spins, all the concentrated cells go right to that little circle on your slide. So you don't have to go hunting for cells. You just go to the, and sometimes on a really cellular body fluid, and you'll know if it's cloudy or if it looks darker yellow, you're gonna count you might count 100 cells in 2 fields. So it'd be click, 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 almost like you're doing your retic. Click, 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 and you're done. So the cytospin's awesome. Unless if you really had a bloody fluid, then naturally you're gonna do a regular, wedge smear. But the cytospins are great. One neat thing that we'll have slides of, when you do a synovial fluid, there are going to be 5 types. The 4th type is associated with crystals. We've already talked about Lesch-Nyhan with uric acid. Well, there's one group that you'll have to identify is called crystal induced. And uric acid are also called monosodium urates when they're in a fluid, a knee fluid or a joint fluid. And there's another thing called calcium pyrophosphate. The monosodium urates look like needles, and they do a polarizer with a neat compensator in the scope as well. And they look like needles, blue and yellow needles. Well, if it's the pseudo-gout, that are these other crystals called calcium pyrophosphate, they're these little rhomboid shapes, and they're yellow and blue. So crystal-induced gout, when you get into a synovial fluid, the doctor has to order also crystal identification, and you at your work would have the capability of using polarized light. We had a polarizer we could add at St. E's. So the doctor has to tell you he wants you to look for crystals because he thinks their joint pain and inflammation is because of something like gout. So that's a neat one with synovial fluids. That probably has the most extra stuff, I'd say. Okay, so let's go. I'm going to give you some problems, and you're going to turn them, put Monday the 19th. I think I have you at noon. So 1, and I'm just going to give you averages, and I'm going to give you if it's diluted, and I'm going to give you how much area. You got to plug it in, okay? So we're going to do a CSF, and it is clear, colorless. So the area is the entire grid. The dilution is none. The red cells, there were 25 and 28 on side 1 and side 2. The white cells, there was 10 and 9. Okay, so that's the first one. I'll just give you 2. Then we're going to do a serous. Oh, here, I'm sorry. I didn't turn it back for you to see. Talking away, and you guys aren't seeing what I'm writing. Okay, does everybody have that? So you need to know, I need to know the red count and the white count for that fluid. And when you do the count, I on this would show your work because you're going to get in the habit of seeing it written out. And then the second one is the serous fluid, and we're going to do yellow cloudy, and it's going to be the area will be the center square, and the dilution will be 1 to 2, and the red and the white Okay, so that's your second fluid. So that it will be due, and that'll be for 10 points on the 19th. So if you want to put that date on it, then you know that's when it's due. And you need to show me your work. So you need to put it in the formula, and this is the terms you got to understand. So if I say the whole grid, you know your area is going to be 9. If I say the center square, what's your area?
1.
1. I said the center square is 1. When you count 5/25ths, it's only 0.2. So I said, but when I gave you on the problem, I didn't say 5/25ths. I said the center square you counted. That means the whole square, so that's 1. Okay? So let's start lab at 10:30, and what I said we're gonna do is only the 4 urines. I gotta run the test up to Karen. We still gotta, Lorian has to do the machine, and then we gotta run our patients. I'm gonna run off the key I have so people can get started. What I'm gonna do is spin the 6 from Urgicare, and then we'll do, so just come back at 10:30, and we will get started in lab, and then we'll break for lunch at 11:30.